Welcome everyone to this video on psychopharmacology. We'll be exploring the fascinating world of medications used to treat mental health conditions. I'm excited to share this information with you. If you are new here, do not forget to subscribe, like, and share. Let's begin by looking at some historical perspectives. In the early 20th century, mental health treatment involved various somatic therapies. These included insulin shock therapy, wet sheet packs, ice baths, electroconvulsive therapy, and even psychosurgery. Before the 1950s, our options were limited. Sedatives and amphetamines were the primary psychotropic medications available. The landscape of psychopharmacology changed dramatically after the 1950s, with the introduction of antipsychotics, antidepressants, anti-anxiety medications, mood stabilizers, and sedative hypnotics. As nurses, we have a crucial role in administering psychotropic medications. It's essential to understand the ethical and legal implications involved. Remember that most states respect a patient's right to refuse treatment, except in emergency situations. Assessment is a cornerstone of our role. Before starting psychopharmacological therapy, a thorough baseline assessment is vital. This includes a comprehensive history and physical examination, an ethnocultural assessment, and a detailed medication assessment. Medication administration and evaluation are key responsibilities. We are in a unique position to monitor patients closely for side effects and assess the therapeutic effectiveness of medications. Our observations are critical to patient care. Patient education is paramount. We must translate complex information into terms patients can easily understand. Education should cover why the medication is prescribed, when and how to take it, potential side effects, who to contact with questions, and when to contact the physician. Let's delve into some core concepts. Neurotransmitters are chemicals stored in the axon terminals of the presynaptic neuron. Their release into the synaptic cleft, stimulated by an electrical impulse, determines whether another electrical impulse is generated. Receptors are molecules on the cell membrane that serve as binding sites for neurotransmitters. How do psychotropic medications work? They primarily affect the neuronal synapse. This leads to changes in neurotransmitter release and the receptors to which they bind, ultimately influencing brain function. Now let's discuss antidepressants. These include SSRIs, SNRIs, TCAs, and MAOIs. They are indicated for major depressive and dysthymic disorders, as well as other disorders through the use of atypicals. Antidepressants work by increasing the concentration of norepinephrine, serotonin, or dopamine. Here are some common selective serotonin reuptake inhibitors, or SSRIs. These include citalopram, Celexa, escitalopram, Lexapro, fluoxetine, Prozac, paroxetine, Paxil, Paxil-CR, sertraline, Zoloft, and vortioxetine, Trinellix. It's crucial to be aware of drug interactions with SSRIs. Certain combinations can lead to serious adverse effects. For example, combining SSRIs with buspirone, TCAs, selegiline, St. John's wort, or MAOIs can result in serotonin syndrome. Serotonin syndrome is a potentially fatal condition of serotonin overstimulation. Immediate cessation of offending drugs and comprehensive supportive intervention are essential. Serotonin norepinephrine reuptake inhibitors, or SNRIs, are another class of antidepressants. Common examples include desvenlafaxine, Pristiq, Cadezla, duloxetine, Cymbalta, levominacipran, Fetsima, and venlafaxine XR, ER, IR, Effexor. Remember that antidepressants can also have off-label uses, such as pain control and anxiety reduction. Tricyclic antidepressants, or TCAs, are another type of antidepressant. Common examples include amitriptyline, Elavil, amoxapine, Ascendin, clomipramine, anafranil, desipramine, norpramine, doxepin, Sinequan, Zonalon, Silenor, imipramine, tofranil, and nortriptyline, Pamelor. Nortriptyline is often used first due to fewer orthostatic hypotension and anticholinergic side effects. Drug interactions with TCAs can be significant. Combining TCAs with MAOIs can lead to high fever, convulsions, and even death. St. John's wort and tramadol can increase the risk of seizures and serotonin syndrome. It's vital to carefully review a patient's medication list before prescribing or administering TCAs. Monoamine oxidase inhibitors, or MAOIs, are another class of antidepressants. Common examples include phenelzine, Nardil, tranylcypromine, Parnata, isocarboxazid, Marplan, and selegiline, Emsam. MAOIs have numerous drug interactions that we need to be aware of. Combining MAOIs with SSRIs, TCAs, atomoxetine, duloxetine, dextromethorphan, venlafaxine, St. John's wort, or ginkgo can lead to serotonin syndrome. Other interactions can cause hypotension, psychosis, agitation, seizures, or hypertensive crisis. Dietary restrictions are crucial for patients on MAOI therapy. These medications interact with tyramine, an amino acid found in certain foods. Patients must avoid foods high in tyramine, such as aged cheeses, raisins, red wines, and smoked meats. Moderate tyramine foods like Gouda cheese, yogurt, avocados, beer, coffee, and chocolate should be eaten occasionally. Safety is paramount when planning and implementing care for patients on antidepressants. Be aware of common side effects like dry mouth, sedation, and nausea. Sexual dysfunction can also occur with SSRIs or SNRIs. Cardiac issues, serotonin syndrome, and other adverse reactions can be dangerous or even fatal. Let's move on to anti-anxiety agents. These medications are indicated for anxiety disorders, anxiety symptoms, acute alcohol withdrawal, skeletal muscle spasms, convulsive disorders, status epilepticus, and preoperative sedation. They primarily work by depressing the central nervous system, with the exception of buspirone. They also activate gamma-aminobutyric acid, or GABA. Anti-anxiety medications can have increased effects when taken with alcohol, barbiturates, narcotics, antipsychotics, antidepressants, antihistamines, neuromuscular blocking agents, cimetidine, or disulfiram. Herbal depressants can also increase their effects. Conversely, cigarette smoking and caffeine consumption can decrease their effects. Common anti-anxiety medications include alprazolam, Xanax, chlordiazepoxide, Librium, clonazepam, clonopine, diazepam, Valium, and lorazepam, Ativan. Avoid these medications in patients with a substance abuse history. Ideally, they should be used for short-term only, as dependence and tolerance can develop. If used long-term, the dose needs to be tapered slowly to avoid withdrawal symptoms. Now, let's discuss mood-stabilizing agents. Lithium carbonate was once the drug of choice for bipolar mania. Some anticonvulsants are also FDA approved for mood stabilization, and some second-generation antipsychotics have benefits for managing the disorder. Common mood-stabilizing agents include lithium, escalith, lithobid, valproate, Depakote, carbamazepine, tegretol, carbitrol, equetrol, oxcarbazepine, trileptal, and lamotrigine, lamictal. Bipolar disorder is characterized by cycles of depression and manic episodes. Effective medication reduces these ups and downs. Lithium was initially identified as an antimanic, but is effective for stabilizing mood swings in bipolar disorder. Many drugs can either increase or decrease the effectiveness of mood stabilizers. Since lithium is a salt, anything that depletes sodium can increase the risk of lithium toxicity. Other drugs that increase serum sodium levels also affect lithium levels. Safety issues and nursing interventions are crucial for patients taking mood stabilizers. Lithium toxicity is a significant concern. Instruct patients to report medications, encourage fluid intake, and educate them about monitoring lithium levels. Assess suicide risk. Instruct patients to maintain sodium intake and assess for hyponatremia symptoms. Let's move on to antipsychotics. These medications are also called neuroleptics. Their primary benefit over time is the alleviation of psychotic symptoms, such as hallucinations and delusions. However, they can also cause side effects that interfere with normal movements, including acute dystonias, Parkinson-like symptoms, and tardive dyskinesia. Antipsychotics primarily work by blocking dopamine receptors. Atypicals focus on blocking specific serotonin receptors. Benzodiazepines facilitate the transmission of the inhibitory neurotransmitter gamma aminobutyric acid, or GABA. Psychostimulants increase norepinephrine, serotonin, and dopamine release. Antipsychotics are primarily used for the treatment of schizophrenia and other psychotic disorders. Selected agents are used in the treatment of bipolar mania. Others are used as antiemetics in the treatment of intractable hiccups and for the control of tics and vocal utterances in Tourette's disorder. Common antipsychotic agents include first-generation antipsychotics, also known as typical antipsychotics. Examples include chlorpromazine, thorazine, haloperidol, and prochlorperazine, compazine, which is used for schizophrenia and anxiety. Second-generation antipsychotics, also known as atypical antipsychotics, are another class of antipsychotic agents. These include aripiprazole, Abilify Aristada, brexpiprazole, Rexulti, cariprazine, Vraylar, clozapine, Clozaril, lurasidone, Latuda, olanzapine, Zyprexa, quetiapine, Seroquel, risperidone, Risperdal, and ziprasidone, Geodon. Contraindications and precautions exist for both typical and atypical antipsychotics. Be aware of specific conditions and patient populations where caution is advised or the drugs are contraindicated. Drug interactions and adverse effects are important considerations with antipsychotic medications. Antihypertensives can cause additive and potentially severe hypotension. CNS depressants can have additive effects. Be aware of drugs that prolong QT intervals, trigger orthostatic hypotension, or have anticholinergic effects. Extrapyramidal side effects, or EPs, are a significant concern with antipsychotics. These include pseudoparkinsonism, akinesia, akathisia, dystonia, oculogeric crisis, and tardive dyskinesia. Understanding the symptoms, treatment, and management of these side effects is crucial. Neuroleptic malignant syndrome, or NMS, is a rare but very serious life-threatening adverse reaction. It is most common with first-generation antipsychotics. It is characterized by fever, altered mental status, muscle rigidity, and autonomic dysfunction. Treatment involves immediate discontinuation of the drug and supportive care. Let's discuss sedative hypnotics. These medications are indicated for the short-term management of various anxiety states and the treatment of insomnia. Selected agents are used as anticonvulsants, as preoperative sedatives, and to reduce anxiety associated with alcohol withdrawal. They primarily work by depressing the CNS and enhancing the activity of gamma aminobutyric acid, or GABA. Sedative hypnotic agents are classified into different chemical classes, including barbiturates, benzodiazepines, and miscellaneous. Examples include amobarbital, butabarbital, butisol, pentobarbital, nembutal, phenobarbital, luminal, sulfoton, secobarbital, seconal, estazolam, flurazepam, temazepam, restoril, triazolam, halcyon, esopiclone, lunesta, Ramelteon, Roserem, Zaleplon, Sonata, Zolpidem, Ambien, and Lemborexant, Divigo. Contraindications and precautions for sedative hypnotics include known hypersensitivity, pregnancy, lactation, severe hepatic, cardiac, respiratory, or renal disease, children, patients with hepatic, cardiac, renal, or respiratory insufficiency, and those who are suicidal or have been addicted to drugs. Be aware of potential interactions with sedative hypnotics. These interactions can vary depending on the specific agent, such as barbiturates, benzodiazepines, esopiclone, zaleplon, zolpidem, and ramelteon. Safety issues in planning and implementing care for patients on sedative hypnotics include observations of abnormal thinking, behavioral changes, unusual behavior changes, complex behaviors with amnesia, and the need for careful evaluation of new behavioral signs or symptoms. Let's move on to agents for attention deficit hyperactivity disorder, or ADHD. These medications are used for ADHD in children and adults. Amphetamines are also used in the treatment of narcolepsy and exogenous obesity. Bupropion is used in the treatment of major depression and for smoking cessation. Clonidine and guanfacine are used to treat hypertension. CNS stimulants increase levels of neurotransmitters, mainly dopamine and norepinephrine. Their effectiveness in treating hyperactivity is based on the activation of dopamine D4 receptors in the basal ganglia and thalamus, which depress motor activity. Common ADHD agents include methylphenidate hydrochloride, Ritalin, dextroamphetamine and amphetamine, Adderall, and guanfacine, Intuniv. CNS stimulants are contraindicated in individuals with hypersensitivity to sympathomimetic amines, advanced arteriosclerosis, cardiovascular disease, hypertension, hyperthyroidism, glaucoma, agitated or hyperexcitability states in patients with a history of drug abuse during or within 14 days of receiving therapy with MAOIs in children younger than age 3, and in pregnancy and lactation. Be aware of interactions with CNS stimulants, dexmethylphenidate and methylphenidate, atomoxetine, bupropion, and alpha agonists. When planning and implementing care for patients on ADHD agents, monitor for side effects such as overstimulation, restlessness, insomnia, palpitations, tachycardia, anorexia, weight loss, tolerance, physical and psychological dependence, nausea and vomiting, constipation, dry mouth, sedation or rebound syndrome, potential for seizures, liver damage, and new or worsened psychiatric symptoms. Patient and family education is also crucial.